Hello, my name is Veronica Ajewale. I'm an associate professor of pharmacy practice and the director for the Community Engagement Core of the NIH-funded Center for Biomedical and Minority Health Research here at Texas Southern University. I want to say a big thank you to you and the community members for joining us for today's program. We are really excited that we will be sharing a lot of great information alongside the experts or speakers and panelists that will be leading us into this conversation. So please have your questions ready. We would have an opportunity to take your questions after today's presentations. So thank you again for joining us, and we look forward to our continued collaboration. Thank you.
Okay, good evening, everyone. I'm Virgil Elkins, proudly serving as the project manager for the Texas Southern Center for Biomedical Minority Health Research Community Engagement Core, and we welcome you tonight to the Protecting Young Lungs, Essential Asthma Care for Children and Families. So before we get started, I want to go over a couple of announcements real quick. We want to welcome you and thank you for joining us today. There will be a Q&A session after our guest speaker. If you are joining us online, we ask that you put your questions in the chat box. We have someone monitoring those questions. Also, if you're joining us online, be sure to sign in using the link that is in the that is in the webinar chat box. I want to also say thank you to our sponsors. For Aflac, Walmart, and Aetna, we truly appreciate you all's support. Also, on behalf of the Center for Biomedical Minority Health Research, we want to send a special thank you to Dr. Ajewale and the team. And also send a special thank you to our partners. Today we are here at the Brenda and John Duncan Family YMCA. And just to give you a little bit of an overview of their organization, I'll read to you what they are about. So the Brenda and John Duncan YMCA, which is located in Spring Branch neighborhood of Houston, has been proudly serving the community since 2003. Originally known as the Westside YMCA and located off of I-10, the YMCA has been committed to strengthening the Spring Branch community since the 1970s. The Brenda and John Duncan YMCA provides services to move us forward in the areas of youth development, healthy living, and social responsibility. It's based out of the state-of-the-art 50,000 square feet facility. The Y includes a wellness center, a natatorium, group exercise room, gymnasium, and covered pavilion. And their program offers the following activities. It's 40 group exercise classes per week, personal training, senior-specific Forever Well program aimed at eliminating loneliness in seniors, youth and adult swim lessons, youth and family enrichment programs, before and after school programs, holiday and summer camp, and much more. The Brenda and John Duncan YMCA is a part of the YMCA of Greater Houston, offering more than 21 locations, all included in the citywide membership. It was founded in 1886. The YMCA of Greater Houston remains committed to the health of more than 500,000 people, helping families grow and thrive through programs and services at locations across Greater Houston. Strengthening the community is our cause. Together we can connect, active, engage, in Greater Houston area residents to build a better us. Thank you to the Brenda and John Duncan YMCA. Before my colleague to speak more on the EQB program here at Texas University.
Hi, good afternoon, you guys. Thank you guys for joining us in person, and for our online viewers, thank you for joining online. My name is Mark Ibarra. I'm the Clinical Research Coordinator at Texas Southern University. Here at TSU, we're starting up a new program. It's called the Equitable Breakthroughs in Medicine Development Program. It's a long name, but all good. The main purpose of this program is to bring clinical research trials to underrepresented populations in our community, specifically in Houston. We want to look at the African American and the Latino American population, specifically because if you look at data like you guys saw in the video earlier, we tend not to participate as much in clinical research. We really want to help bridge this gap.
All right, so we want to formally welcome you all to the Protecting Young Lungs, Essential Asthma Care for Children and Families Health Education Seminar. As stated before, if you are joining us online, please scan the QR code or click the link so that you're properly signed in. Also, to receive your CHW CEU credits, please make sure you sign in online. And then we will have a question and answer period after the presentation. But if you have any questions, please post them in the chat box, and we have someone monitoring that chat box. Our guest speaker today is Dr. Andrew Taylor. Dr. Taylor joined the Texas Southern University Respiratory Therapy faculty in 1999. Dr. Taylor has been the program director since January 2022. And in this role, Dr. Taylor is responsible for overseeing all aspects of the respiratory therapy program, including classroom and clinical teaching, continuous curriculum development, communication with all program stakeholders, ongoing program planning and assessment, and fiscal management. Dr. Taylor has 28 years of clinical experience as a respiratory therapist. Without further ado, I present to you Dr. Andrew Taylor.
Thank you. Yes, sir. Thank you so much for that warm introduction. And I do want to thank you to those of you who have joined us in person, and certainly say a heartfelt and a sincere thank you to Mr. Virgil Elkins for the invitation to come and to share on this very important topic, protecting young lungs, essential asthma care for children and families. And I'm going to start off just by giving you an overview of the entire talk, what we're going to talk about tonight. We'll start off with defining asthma and identifying some of the common asthma triggers, and then we'll discuss treating and preventing asthma episodes. I do want to say here at the very beginning that this talk is specifically about asthma in children, and by children we mean kids who are between the ages of 6 and 11. The current scientific guidelines suggest that when a kid reaches the age of 12 years old, they're really treated like an adult. So 12 years old and above, that asthma criteria, it's not that different, honestly, but there is a distinction. So if we have questions about 12 years old and older, certainly during the question and answer session, we can try to address those. But mostly what I'm talking about is specifically children 6 to 11. We're going to also discuss the daily monitoring of asthma, and then finally try to encourage, throughout the talk, encourage vigilance on behalf of parents and children to try to find that place where they can flourish as an asthmatic. All right, so let's get started dealing with the definition of asthma. So asthma is a chronic respiratory disease that causes airway inflammation and is defined by the history of certain respiratory symptoms. So my symptoms are already up here. This was my point of participation from you. But if you think about asthma and its symptoms, wheezing, shortness of breath, chest tightness, and cough, these are the classic signs that a person is having what we call an asthma attack or an asthma episode. These symptoms do vary in intensity over time. Sometimes they can be really bad, sometimes not so bad. And this includes classically a variable expiratory airflow. So the idea of the air that the patient is able to get in and out will vary, okay? And that becomes a very significant thing. This is why patients complain of chest tightness and shortness of breath. Now, how common is asthma? So in the United States, we're thinking 18.4 million adults, as well as 6.2 million children. So that's 25 million people in the United States that have asthma. Worldwide, 235 million people have asthma. So this is not a disorder or a disease that's rare. This is something that's very widespread. So if you do suffer with asthma, it's nothing to feel bad about or excluded or ostracized about. It's very, very common, okay? So who is at risk for asthma? Certainly there is a genetic component, and so we highlight genetics there. Also, there are other host factors that you can see on the slide. And then the environmental factors, which are the ones that people tend to focus a lot on. These are both indoor and outdoor. So it may be something that's out in the environment. It could be something that's inside your home, like dust, for instance. Could be a pollutant that causes or triggers asthma episodes. Certainly, tobacco smoke is something that we want to be mindful of, either smoking ourselves or in secondhand and being around people or in environments where tobacco smoke is prevalent. Other risk factors include food additives. This is something that kids really have to pay attention to, be aware of, that certain foods, additives, preservatives, other things that can trigger allergy, we have to know those and pay attention to those. And be very careful soon from a friend or from ignorance. If there's certain things that have been prepared with things that we know trigger us, we have to be careful. Exercise-induced asthma is also an important thing to pay attention to, especially for kids, because we want them to get up, get out, exercise, and take part in all kinds of activities. But we need to be careful when we do those things as well. Be wise about that. And then finally, I'll hit on the emotional stress, and that's for everybody. Stress can bring on asthma episodes as well. So this next slide is pretty important because it really helps us to understand a lot of what happens in asthma and what we need to accomplish in the area of medications. If we're using medications to control asthma, then this slide becomes very important because it talks about really what's normal in the normal airway and then also what happens in the asthmatic airway. And so for the normal airway, notice how large the lumen or opening is for the airway on the normal side. And then there are three other things that we want to point out on this particular slide on the normal side. Notice the muscles around the airway. It's what we call smooth muscle, okay? Notice also this light pink layer, which is called tissue. That's the tissue layer of the airway, okay? And then notice also that there's no mucus or sputum inside the airway. So this airway is nice and open and big and patent. We're not going to worry about any wheezing or shortness of breath or airflow difficulty with that airway. It's wide open. Now on the other side, the abnormal side, this is the asthmatic airway. Notice the difference, that the smooth muscle around the airway is tight, okay, and it's clamping down on the airway. So that alone is going to cause that open lumen to be much smaller, okay? Number two, notice the inflammation around the airway. Very, very large, a lot of inflammation in there, okay? That's going to also contract the size of that airway. And then thirdly, notice the green mucus that's inside the airway. Now, the mucus could be white, green, yellow, doesn't matter. If it's in the airway, it's going to cut down on the size of the airway. And that's what's going to give you all of those things together, will give you the characteristic wheezing and shortness of breath and the coughing and the chest tightness, okay? That's where that comes from. So this is why this is important, because when we think about how to treat asthma and prevent asthma episodes, we need to be thinking about pharmacologic agents, drugs that we take that can address all three of these problems, not just one of them, okay? So one of the questions that I wanted to ask, and we'll get to this again as we move forward in the presentation, is, what drugs are common for asthmatics to take? What drugs do we already have at home? What drugs do we carry around with us when we go to school? That kind of thing. I'm thinking people would say things like albuterol, Ventolin, Proventil, okay, which is really all the same drug, but those are drugs that are very, very common. Most people that have breathing problems are going to have them in their medicine cabinet or in their pocket. But the problem with that particular drug and drugs like it is that it only addresses one of these problems. It only addresses the smooth muscle, okay? It does nothing for the inflammation. It does nothing for the mucus. So consequently, The drugs are going to make you feel better right away, but they're not going to address the long-term problems. Okay? So, so what happens in the lungs? This is kind of a review. We're having a little quiz. Let's talk about these things. What happens in asthma? Smooth muscle tightens. We've got increased production of mucus. We say it's thick white. Of course, if the patient has an infection or something, it could turn yellow or green. And then mucus plugging in severe cases, and finally, airway inflammation. So asthma is diagnosed then based on the history of those symptoms. When those symptoms recur and happen over and over, that's a big part of how we diagnose asthma. Also, really big piece of it is what we call pulmonary function testing, which is a whole battery of tests. And depending on the results of those tests, then we diagnose individuals with having asthma. And what we really want to know in doing those tests is, how do patients do before and after those drugs like albuterol? Okay, does it really make a difference? Classically, it will, but again, it's a short-term, short-lived difference. So for the rest of my time, I'm going to actually use a case study to talk about some of the common things that we want to share about treatment and prevention, okay? And we're going to talk about this young lady named Hannah. She's 8 years old. She's in the 3rd grade, okay? So Hannah, again, 8-year-old 3rd grader at Happy Hill Elementary. She loves school, playing with her friends, and she loves to learn new things. Hannah was diagnosed with asthma 11 months ago and was doing fine until the weather started to change. Now she's having a very hard time managing her symptoms. 4 to 5 times a week, Hannah experiences wheezing, has a hard time catching her breath, coughs a lot, and feels tight in the chest. She wakes up 1 to 2 times per week with these symptoms, and she has missed school at least 1 time every week in the last month. Her current asthma medications include albuterol, an albuterol inhaler that she takes when she has symptoms, and she has another drug called Duoneb, which actually is albuterol and another drug called Atrovent mixed together, very, very common. And she takes this in a nebulizer before and after school, and when she wakes up, short of breath at night. These medications give Hannah relief, but the relief does not last. So how would you describe Hannah's asthma? Okay, how would you describe it? Under control? Okay, or out of control. Okay, good. So just in your own words, really, how would you describe it? Is it good? Is it bad? Do we need to work on it? Okay, right? So we need to do some work for sure. So the second question really, is it out of control or under control? I actually just want to highlight, yeah, it's definitely out of control. This is why nighttime symptoms, that's a classic no-no. Okay, when you're waking up at night, you're supposed to be sleeping at night, and so you can't rest because you're having symptoms. She's missing school or any other activities, that's not good. And then her asthma symptoms 4 to 5 days a week. That's a big piece too, because for it to really be under control, we want those symptoms to be down to 2 days a week or less, okay? And hers is it's most of the days of the week. So one of the main things that I want to drive home in my time is asthma is not like a lot of diseases that we encounter. For a lot of diseases, we can have a problem, we go to the doctor, we get a solution, and that solution kind of takes us forward, and we can kind of, in a sense, forget about it because we've got that medication or intervention, and it's fixing the problem. Asthma is not like that. So if you're an asthmatic or a parent of an asthmatic, understand this, that we want to start therapy, we want to continually assess that therapy, we want to adjust it, and then periodically we want to review it. And don't feel bad about that. Don't feel bad about this sense of having to continually monitor what's going on with your child or with yourself. because that is going to be a part of life for you. That's just the way it is. But there are people who manage asthma very well. But even in the action plans we're going to talk about, there needs to be this sense that adjustments can be made, when the weather changes or when triggers are encountered and you're on a certain medication, and it may be as simple as upping the dosages or taking it more often, but don't get stuck in this sense of set it and forget it. You have to start it, but there has to be continual assessment, adjustment and review. So for Hannah, she has what is called, based on her symptoms, she has what's called moderate persistent asthma. So what treatment should we recommend for her to attempt to gain control over her asthma? What meds is she currently taking? So we review that and say she's currently taking albuterol and Duoneb, which is albuterol and Atrovent. And what do these drugs really do? You hear these terms called rescue medications or quick relief medications. That's basically what they are. They're for giving a patient relief when they're having problems, but they do nothing about the long-term effects of asthma. And so one of the points we make here is that current scientific guidelines, in those guidelines, there are no guidelines that only recommend those drugs. Yes, you should have them in many instances, but there are no guidelines that only recommend those drugs. That's the old way of thinking about asthma. Today, we know that we need to think about it a little differently. And there is also science that suggests that if that's the only type of medication that you're taking, that's going to lead to greater episodes of you showing up at the emergency room and or something worse happening. So we review this one more time to say, the drugs that she's on are only addressing the smooth muscle, not addressing those other issues. So what do we need to change? Here are the recommendations for moderate persistent asthma. They include, number one, she needs a visit to her provider, doctor, nurse practitioner, physician assistant. And when you go to your provider, take your medications with you. Take the inhalers with you so that we can get some training or retraining on how to appropriately and correctly take those medications. Because so often the problem is in the process of how you take the medicine. And then the new drugs that we need to add, the main drug that we're going to recommend for her is a steroid. What we call corticosteroids. You can just call them steroids. We can use the abbreviation ICS. They are inhaled corticosteroids. Here's a list of them. You may recognize some of them, but there's a long list of them. But I just put them there just for the sake of, hey, maybe you recognize some of them. There are actually 3 different options for a person who's 6 to 11 years old that has moderate persistent asthma as it relates to medications. There are 3 different options, but all the current asthma guidelines recommend these types of drugs. So no matter which option you use, all of them have included something about steroids. So why steroids? Because steroids are going to deal with those other parts of asthma that the albuterol and the Atrovent and drugs like that don't deal with. And really, they are anti-inflammatory and they help to avoid, the problem in the first place. So instead of reacting to the problem, let's try to avoid it in the first place. All right, so the other things we recommend are coaching, some asthma coaching. So what that means really is the idea of showing the asthmatic and their parent how to actually take the medication, making sure we're doing it appropriately, and then coaching on some of these other devices that we're going to talk about. We need a written action plan to say, hey, we're doing fine in December, but what happens in January if we have a little flare up? How do we need to adjust the medications? we want to have that written down for the patient and for the child, the child and the parent, to help them to navigate that so that they don't have to necessarily always go back to the provider. Between the provider and the parent, we can have an agreement that if this happens, then do this with the medication, right? And then a follow-up appointment, okay? Nobody wants to follow up, but we have to do some follow-up. So if she's having these kinds of problems, they're pretty significant problems. So we need to get her on something that works, try something that works, but then have the follow-up, and we'll see that in the rest of the case, okay? So here are 4 different ways to take respiratory medications. All these are inhaled routes of administration, through inhalation. But all 4 of these, although we inhale all 4 of them, the breathing pattern is different for most of them. So if we're not breathing correctly when we take the medicine in, we're not getting the medicine, okay? And so that's why we need some coaching and some training. Here's a copy or picture of the asthma action plan. Is the asthma in good control? Notice the guys are playing here. Is it kind of a cautionary period where we need to be careful, or are we in a danger zone and we need to go to the emergency room or call 911? So this is an example of what the action plan looks like. The other equipment that I want to go over are these devices called spacers and holding chambers, especially if we're taking corticosteroids or some type of steroid. Most often, especially if it's in a MDI form, we want to be sure that we're using a spacer or a holding chamber to take that medication so that we don't have any negative effects of taking it. Certainly our physicians and providers can help us figure out where and when to get these. And in addition to that, if we don't or cannot access this for any reason, I'm sure we have some of these around the house. You guys know what this is? It's a toilet paper roll, okay? So eventually, you're gonna have some of those, okay? So even in our textbooks in respiratory therapy, when we talk about pharmacology, you'll see these in the book, okay? Because, hey, you've already paid for it. It belongs to you, okay? All right. So the medications that we actually put Hannah on include fluticasone and salmeterol, which are mixed together in a formulation called Advair. And we're gonna put her on kind of low dose, 45 and 21, that's fluticasone and salmeterol, 1 inhalation daily. She'll still have her albuterol inhaler as needed, but hopefully as she starts to take the Advair, then she won't have to use the albuterol as much. And hopefully we get to the point where she doesn't need it much at all. So 2 weeks after, now we fast forward 2 weeks, 2 weeks after visiting her provider and starting her new medications, Hannah is feeling much better. She is no longer waking up during the night, which is great, and she has not missed school because of her symptoms. So Hannah is still, though, experiencing some wheezing, coughing, and chest tightness about 2 to 3 times a week. So she's definitely headed in the right direction, but maybe not in the sweet spot just yet. So what do we want to recommend now? Okay. Since she is doing better, but we still want to try to, remember I talked about this earlier, gain control, don't get stuck in a particular mode, reassess and adjust if needed. So what I'd like to do is increase her steroid dose some, and this is going directly by the guidelines, and the medication that she was already on, but we're going to bump it up, okay? The steroid side more than anything, okay? And she still continues to have the albuterol inhaler as needed. And so what we hope is that these adjustments will take her closer to better control. Okay, again, start, assess, adjust, review. Don't feel bad about that. It's just a part of the process until we get to the sweet spot, okay? All right, so 3 months later, believe it or not, 3 months later, after her last provider visit, Hannah returns for her follow-up visit. She reports that she is no longer having daily asthma symptoms, except when the weather changes suddenly. She continues to do well in school and is thinking about trying out for her school's soccer team. Okay, so what do we recommend now before I go to the next slide? Okay, y'all have gotten all of this good teaching. What do y'all think? Based on her symptoms now, look at where she started off and look at where she is now. So what are we thinking? Is she in a place, she's not waking up at night anymore. She is doing well in school. She's flourishing. She has some symptoms every now and then, but nothing like she had before. So our recommendations then, our recommendations would be, we're going to maintain present therapy. We're going to stay right where she is, but we're going to follow with the provider in 6 months. We're going to continue at home to do our diary to kind of track how she's doing. And then there's one other device that I didn't mention earlier when I talked about the equipment, and that device, you may be familiar with it. It's called a peak flow meter. The peak flow meter is going to allow her to blow into it and track her flows, okay, her expiratory flows. And she can do that twice a day. If she's feeling, even when she's feeling really good, do that, because that'll give her a baseline of, hey, am I doing good today? Am I kind of moderate today? Am I really, really not feeling well today? And then it kind of gives us an objective view of, yeah, I feel bad, and I can see too that I'm not doing well. So we'll document that. We'll write those numbers down, and the asthma coaching will help teach you how to do that as well. All right, so then we look at some add-on therapies. And the reason I put the add-on therapies in here was because we want to make sure that we know that, yeah, there is drug therapy that we can do, but there are a lot of things that we can do to try to help people who really have a lot of problems with asthma. The science is progressing here. So just know that if you're in a position where you're really having a hard time, talk to your doctor about it and think about other ways that we can intervene to help get you to a place of flourishing. Okay? And then, of course, we included the vaccinations. What we don't want is to have the flu or to have COVID and have asthma, right? That's out of control. So please follow your county and city recommendations for vaccinations, okay? This is wisdom speaking, that we need to take advantage of the science that has been done in the area of vaccinations to avoid those problems on top of the asthma problem. Okay, so I say this again with regard to the way in which asthma ought to be approached. I've said it several times, and I planned on saying it several times, just to help us realize as parents and asthmatics, because sometimes we feel a sense of stigma because we have something maybe that some of our peers don't have. You know, you feel like you're different or you're weird. You're not. You just have asthma, and there are 240 million people in the world who have it. So just seek out the information and help that you need, and understand that you can get to a place where you're doing really, really well, but don't get stuck in a place where, hey, I've been taking this medicine for 10 years, or I've been taking it for 5 years. So what? Or if you need to assess and adjust, do it, and make sure that you're reviewing that regularly with your physician. So it looks like I'm giving you 2 minutes back, but we are at the point now for questions and answers, our Q&A period. If there are any, we'll take questions.
We had one, Dr.
Okay.
It was, so they were asking, is there a season for high and low?
Oh, you want to say it? You can use this one if you want to.
So one of the questions, I wrote it down here.
Mm-hmm.
Is there a season for high, or is there a high and low seasons for asthma attacks?
Then I would say the answer to that question is yes. Okay, so in general, in our business, we say when the weather starts to change from warm to cool, we call that respiratory season. Okay, so all respiratory diseases, typically we see a spike in them. So patients that have asthma and other allergic kinds of respiratory diseases, we see a spike. But then also what asthmatics have to do is really understand their trigger. So because it's not always the weather, right? So, and sometimes the trigger is in the house with the person. And the trigger may be an indoor trigger, not an outdoor trigger, okay? And you may be a child who loves your dog or you love your cat, right? And your whole childhood you suffered with asthma until the dog died or the cat died. And now you cured, okay? Because you never knew that the trigger was right there in the house with you. But there's pollen, and if we look at the weather reports, then we see these peaks and the peaks and valleys of the outdoor triggers as well. So sometimes that's season change, but also it could be weather pattern change. So unfortunately, for the person who asked that question, it's a simple answer, but it's also complex because the hardest part is you understanding your triggers and which triggers to really pay attention to. Again, we go back to the weather. Sometimes the weather lady or the weatherman tells us about the ozone. Today is a weather watch day because ozone is high. So if that's a particular trigger for you, then knowing that helps you to avoid those problems. In a sense, that may be a day, unfortunately, where we have to stay in more than go out.
So after a child or an adult use the inhaler, how long after can they eat or drink?
Typically, there's no limitation. So once you use your inhaler, as long as you feel like eating or drinking, it's perfectly fine. The eating or drinking should not avoid the effectiveness or affect the effectiveness of the medication. Okay. And so a lot of times what we see with people that have breathing problems, if they're really having breathing problems, they don't want to eat. Okay, they may want to drink a little something, but eating is not what they want to do at that moment. So we have to just go on the wheel of the patient or the person that has the problem.
Okay. And then last question here. In layman's terms, can you explain the levels of asthmatic? Are there extreme cases of diagnosis or are there lower cases of diagnosis?
Yeah, and in layman's terms. So yes, right now there are 4 different levels for asthma. Our person tonight, Hannah, had moderate persistent asthma. That's pretty high on the scale. So moderate persistent, which means it's close to being severe. Okay, severe would be the worst. And the easiest way to do this is probably to say moderate persistent means you're having symptoms most days. Severe means you're having symptoms and worse symptoms every day. Intermittent asthma means you're having, this is the lowest, intermittent is the lowest. You're only having symptoms 2 days or less a week. And then mild would mean you're having symptoms 2 to 5 days a week. Okay, hopefully that made sense. But severe, you're having symptoms every single day. And we've got to figure out how to intervene to lessen those symptoms. Okay, and I've got one more question. You can read it out if you want to.
So I am a new dad of 2 brand new baby boys. So my question was, how early, I know we talked a lot about like ages 6 to 11, how early do signs and symptoms present themselves in
So
kids?
yeah, all the way down to, ranged all the way down to 4. Now, there are kids who are, just months old who may have some of these symptoms like wheezing. They may have some, but it's hard for them to articulate, right? So usually when kids are really, really small, like less than 4, there's this term that's used, reactive airways disease. The diagnosis of asthma doesn't typically come out until kids can do a little bit more of the testing. But certainly there are kids who are younger than that. But the idea as a dad, you're watching for normal development. You're watching for, kids being able to run and play and jump and do what kids do without having problems breathing. And so then if there's a concern, then that's the time to reach out and talk to your pediatrician. And then hopefully they're not having any major problems that the pediatrician can just handle. But then if they're having some more advanced issues, they really should see a specialist, if it's really an issue. When I say specialist, I mean a pulmonologist, pulmonary doctor who should have their finger on the pulse of where the science is right now. So great question. Hopefully I answered it. Okay.
No, thank you.
Thank you.
Awesome. Thank you so much, Dr. Taylor. We truly appreciate your time and your expertise and your information that you provided to us today.
Thank you for having me.
So we are at the conclusion of the program today. Again, if you are joining us online, please make sure you sign in online to receive your CEU credits. Sign in to receive or to show that you are in attendance today. And then also, if you would, please complete your program evaluation so that we know how to improve or how we're doing with our program health education seminars. I want to briefly go over a new program here that we have going on. It's called the TSU P20 Cure Summer Research Program, and it's a collaboration with Texas Southern University as well as Baylor College of Medicine. And it provides a unique opportunity for students interested in the cancer-related fields. If you are interested in this program, please scan the QR code. The deadline is to apply January 31st, 2025, Central Standard Time. It is for eligible students, include TSU undergraduates, graduate students, and incoming freshmen with a grade point average of a 3.0 or higher. And it runs full-time from June 9th to August 4th, 2025, and it offers a competitive stipend of $4,000 to $5,000 and provides pathways to graduate studies or in careers in cancer research. So please scan the QR code, or you can reach us at 713-313-1233 for more information. We have a couple of important conferences coming up. Here is some of our events that are taking place in January of 2025 and April of 2025. So our maternal and child health education and outreach, this is one of our signature events throughout the year, take place on Friday, January 24th at Texas Southern University from 10 a.m. to 3 p.m. If you'll scan the QR code, actually when you scan our QR code, you'll be able to see all of our events and activities that are coming up in the future. But scan the QR code to register for the event. And both events and activities, we will have mobile units available, vendors, things of that nature, a lot of activities and vendors for you to engage in or engage with. And then in April is our Clinical Research and Engagement Conference, which will take place April 12th at TSU from 9 a.m. to 3 p.m. So we welcome you to join us for those events. Both of the events are hybrid. They'll be in person as well as online. And then just to give you a little overview of our community engagement activities that we have going on throughout the year, these are the topics that we have going on. So our next event will be, again, January 2025, the maternal and child health, followed by chronic kidney disease in February. March, we will host our Healthy Aging Alzheimer's Dementia program. April will be the Clinical Research and Engagement Conference, followed by May, the Self-Care and Emotional Well-Being. Again, follow us on our social media platforms. Also, scan the QR code to find out where these locations will be, where we'll be holding these health education events. And now you can follow us online on all of our social media platforms. Also, again, for more information, please call 713-313-1233 or email us at the cbmhrcommunity@tsu.edu. We thank you again for joining us. Please have a good night and see you next time.
Hello again. My name is Veronica Ajawale. I want to say a big thank you to each and every one of you for joining us for today's program. I am very certain that you have received a lot of great information that you will put to practice as we all grow together to become a healthier community. Thank you to our speaker and our panelists. Thank you for sharing today's content with us. Thank you to our locations. Thank you to our interns, our volunteers, to our sponsors and our funders. Thank you also to the staff of our program, the faculty, and the leadership of Texas Southern University for supporting us in making today's program a success. Most importantly, I want to say thank you to each and every of you, the community members. We appreciate your support. We do not want today's program to end just with today's event. We want you to continue to collaborate with us and engage with us. Our social media platforms are located at CECTX Southern U. On those platforms, you will find engaging information from today's program and all the other programs that we have going on in the Community Engagement Corps. So we implore you to continue to stay connected with us, engage with us as we move forward together in building a healthy and a wealthy community. Thank you for joining us, and we look forward to connecting soon. Bye.